breast cancer therapies, I guess most of you at this point know that there are estrogen receptor positive breast cancers, estrogen receptor negative breast cancers, and HER2 new positive breast cancers. And then there's what's called triple negative breast cancers. So those are kind of the four. Well, actually, those are the three biggest, because if they're estrogen negative and they're HER2 negative, then they're and progesterone negative, then they're triple negatives. So what that means is that estrogen has the potential for possibly triggering and accelerating the growth of certain types of breast cancers, not only in women but in men. And although it's hardly ever talked about, there is an incidence of breast cancer in men that comes out to be about 1/100th the incidence of breast cancer in women, and it has all the same implications as it does in women. You've probably seen some men who've come through here through the Cancer Help Program with it. And there are genetic tests now that can sometimes predict the likelihood of a woman getting breast cancer or not. They're not 100% in terms of their accuracy, but there's definitely a strong familial link. If a woman has a mother or a sister who has had breast cancer, then she's at significantly higher risk for developing breast cancer. African American women have higher rates of breast cancer than non-African Americans. And if it's an estrogen receptor, and so what they do when somebody has a breast tumor is the tumor is usually removed, is biopsied, sometimes removed completely at the time of the biopsy, and studied not only for the cell type, which is what all pathology examinations look at, but also to find out if it has the markings of being an estrogen receptor positive cancer, progesterone receptor positive cancer, or another substance in the body called HER2 new, which is a surface marker on the cancer cells. Estrogen receptor positive cancers, besides conventional surgery, chemotherapy, radiation, are often treated with estrogen blocking drugs. And the estrogen blocking drugs, the one that's been around forever, is tamoxifen. It is effective. It's still used, and the other drugs are. They work in a slightly different pathway, but they have the same ultimate effect of lowering the amount of estrogen in the body that has the potential for making the cancer come back. So the assumption here is that the initial breast cancer is removed. There may not be any other signs of breast cancer in the body, by imaging, by scans, by the blood tests that are used, but there are probably some stray cancer cells somewhere around that can land and then at some point start growing again, and that's what metastatic cancer is when it comes back and starts spreading to other parts of the body, liver, lung, brain, various other organs in the body. If the woman is also treated, or the man is also treated with an estrogen blocking drug for a period of 5 years, seems to be about the average now for these different drugs, it lowers the risk of recurrence of that cancer significantly. The problem has always been that the estrogen blocking drugs have to be taken long term and they're not free of side effects. So that the issue with tamoxifen has always been that it actually increases the risk for uterine cancer, not by a lot, but by a significant percentage. And it also increases the risk for formation of blood clots in the veins. And then blood clots can be locally uncomfortable, but can also break through and travel to the lungs and cause a pulmonary embolus, which can be a fatal condition. It can be pretty scary. The aromatase inhibitors, which is the other class of estrogen blocking drugs, things like Femara and aromasin, they work differently. Let's go back to tamoxifen. Tamoxifen is called a SERM, S-E-R-M, which means selective estrogen receptor modulator. And so the tamoxifen acts like a phony estrogen that sits on the estrogen receptors and blocks the uptake of natural estrogen that's coming from the woman's body. So that even though many women are postmenopausal and not producing a lot of estrogen, they're still producing estrogen. And most of it at that point comes from the adrenal gland instead of from the ovary. It comes from adrenal testosterone, which comes from DHEA, and it is converted into estrogen through a pathway called the aromatase pathway. The aromatase inhibitors block this enzyme, aromatase, which is responsible for that conversion, so it keeps it in the form of testosterone. It doesn't get to estrogen, and so the decreased estrogen then downregulates the tendency for cancer cells to grow and to take off again. HER2/neu, which is this other surface protein marker that occurs, is very susceptible to a landmark drug that first showed up, I guess, about 12 years ago called Herceptin. I think many of you have heard of that. And and that's given by intravenous injection. The others are oral treatments. And if Herceptin is given for 1 year after the woman has finished with radiation, chemotherapy, surgery, whatever she's going to go through, and has that type of cancer, it dramatically reduces the risk of it recurring or metastasizing. Couple of other tidbits about breast cancer are that although radiation is, part and parcel of the whole treatment of early stage breast cancer, radiation itself decreases the risk of recurrence of cancer in that breast. It decreases the percentage of recurrence of cancer in the breast only by about 50%, but it does nothing in terms of preventing metastasis or preventing a later recurrence elsewhere in the body. And it's a big price. I mean, radiation is not a walk in the park. I'm sure there are people here who have gone through it. There's a lot of local discomfort. There's a lot of skin burning that can occur. There's fibrosis that can occur, contraction of the tissues. It's a tough road to go through. And so, my take on it has always been that there needs to be really good reason to do radiation. And if there's something that's going to be dropped for an aggressive cancer, if there's something that's going to be dropped out, radiation would be the first thing I would drop out, with surgery and chemotherapy, if the chemotherapy is necessary, being the main ones to keep in. In the last several years, we've seen the advent of genetic testing, which has really changed the field to some degree. The genetic testing does what they call a 23-gene array, and they're actually examining the tumor for different genes that would predict the likelihood of recurrence of the cancer. If somebody has a very low score on one of these gene tests, then it's not likely that chemotherapy is going to be offered because it's probably not going to add much, in terms of benefit. But the chemotherapy also has lots of side effects, as you know. If someone has a very high score on the genetic testing, then you can bet that chemotherapy is going to be recommended as part of the treatment. In terms of let's see if there's anything else I want to say just about I think that's a pretty good look at the overall treatment that goes down with breast cancer. So what did we have to offer specifically in the onc field, as Michael calls it? Because some women were not going to take any of the estrogen blockers because they did not want to deal with the side effects, or because they had started taking them and started experiencing the side effects. The aromatase inhibitors, the main side effect that keeps people, that takes people away from it, is joint pain. There's significant joint pain that occurs in approximately 35 to 40% of women who take aromatase inhibitors. And so that there's a pretty significant dropout rate where people will stop taking it after they've started. And you need to take it for, anywhere from 2 to 5 years for it to really be of benefit. So there's another pathway of estrogen metabolism in the body, whereby estrone, as the parent estrogen compound, has several different forms: 2-hydroxyestrone, 4-hydroxyestrone, and 16-hydroxyestrone. 2-hydroxyestrone has many of the benefits of estrogen in terms of, being essential for normal tissue maturation, growth, and health, but it doesn't stimulate breast cancer cells. 4-hydroxyestrone does, and 16-hydroxyestrone does. And normally there's a conversion of one to the other. So another way of approaching this would be, how do we block the conversion of 2-hydroxyestrone to 16-hydroxyestrone? Well, there is a natural substance in broccoli that does exactly that. It's called diindolylmethane, abbreviated DIM. And it can be taken as an oral supplement. There are mainstream studies on it, but again, because it's not a potential blockbuster drug, we don't have the several $million studies that are going to have the statistical power to convince the rest of the medical community and the oncology community that it's going to be anywhere near as effective. But we've used it for years, both alongside the other estrogen blocking drugs and sometimes, standalone, because someone couldn't tolerate the other estrogen blocking drugs, and we've seen good results with it. So this is diindolylmethane, DIM. Some of you are probably familiar with that. Now, broccoli is a pretty amazing substance, as are some of the other cole family plants. Cabbage, cauliflower, Brussels sprouts, kale, cabbage. They also produce something called sulforaphane, and sulforaphane also has direct cancer preventing effects. And there's another compound in broccoli seeds called glucosinolate, like glucose and then INOLATE. And that one also has a direct anti-cancer effect. It seems, Chris and I were arguing about this on the way over here today. I had thought that sulforaphane and glucosinolates had independent modes of action. Chris thinks that one converts to the other.
But I'm not sure. I haven't had a connection to actually look it up.
Okay. So anyway, maybe we'll get that and get it down for you so it can go on the website once we figure that out. But in any case, it's a really good idea with all cancers to be using broccoli derivatives because of the sulforaphanes. But in the specific case of breast cancer that is estrogen receptor positive, diindolylmethane that's the specific substance that one would want to be taking.
Are you going to change topics now?
No, I'm staying here for a
Are you going
second.
to talk about 2-methoxyestradiol?
I wasn't going to go there, but would you like to jump in and say that?
Well, I just wanted to say that from my work and my research, the most protective compound is after you have the 2-hydroxy, you convert that via a methylation enzyme, catechol methyltransferase, to 2-methoxyestradiol, which actually has anti-carcinogenic, anti-proliferative properties. That's the molecule that the first stage is 2-hydroxy that you get there with DIM, diindolylmethane, broccoli, having sufficient iodine and having sufficient selenium. Then you want to do the next step, which is converting the 2-hydroxy to the 2-methoxy. And that is assisted by having sufficient or extra methyl B12,
Yes.
methylfolate, trimethylglycine. And then with regard to the 4, which is the most, potentially carcinogenic because it can convert to 3,4-quinone, you can nullify the effect of the 4-hydroxy by the same catechol methyltransferase enzyme assisted by methyl B12 and methylfolate, and convert that to 4-methoxyestradiol, which is neutralized. It neutralizes the molecule so that it's no longer dangerous.
Great, thank you for that. And Debbie Downer's back. Methyl B12 is potentially on the block along with glutathione.
Oral?
Chris, is it going to be oral and IV, do you know?
They haven't clarified that. I assume the injectable, because they would have to remove a lot of products if they removed that.
That's horrendous.
Wow.
That is unbelievable.
Okay. So, testosterone is not necessarily a bad thing for women. I mean, women have testosterone naturally, it's just that men have a lot more of it. testosterone is the hormone that is the most responsible for libido, and most people don't want to give that up, and actually, often welcome some help in that area, especially as we age. So this idea of blocking the conversion of testosterone to estrogen is not a bad thing. By blocking it, you're actually accumulating a bit more testosterone. Testosterone helps muscle mass, it helps mood, and it helps libido. Let's see. I don't know of any natural substances that are useful in the treatment of HER2 new positive cancer specifically. I think Herceptin's really had that one locked up for a long time. Did I mention calcium D-glucarate before for detox? Okay, so a little bit of gastrointestinal physiology here. One of the main jobs of the liver is to help to get rid of toxic substances in the body, which can also include metabolites of hormones that we've produced. And the liver cells go through their process of sometimes binding the toxins to other substances, and then they secrete it into the bile, which is manufactured in the liver. Bile gets stored in the gallbladder, and then the gallbladder squirts that bile into the intestine under the influence of a meal coming through, especially a fatty meal. The bile, besides containing these toxic substances, also contains, it has an emulsifying property so that it takes fat and it breaks the fat down into microscopic droplets so that the enzymes produced by the pancreas can actually help to digest the fats and allow you to absorb the fats into your system. So bile has this dual mode of action, detoxifying and helping with fat, with fat digestion. Once the bile has gotten into the intestinal tract, sometimes the substances that it's taken down there, including the toxins and some of these breakdown products of the hormones, are reabsorbed from the intestinal tract and get back into the circulation and then keep going around so that we don't really get rid of them. And that's called the enterohepatic recirculation. It's not a great thing if you're trying to get rid of toxins. You want stuff to be taken out and carried out with the stool when you have your next bowel movement. So there are some strategies that have been developed to try to prevent that the enterohepatic recirculation from carrying that stuff back into the system instead of getting excreted. And one of them is a substance called calcium D-glucarate, Glucarate. And it's not about the calcium in it. Calcium is just the salt that binds the glucaric acid. And glucaric acid interferes with an enzyme that's responsible for allowing these substances to get reabsorbed into the body. So giving calcium D-glucarate as an over-the-counter supplement in any kind of cancer is good for detoxification, but especially in the, and also for detoxification for people with other conditions that are non-cancer related. It also has this component of being able to reduce the hormone load as well. So if you've got too much estrogen on board and you're trying to get it down naturally, the calcium D-glucarate works for that as well.